To understand the anatomy, this is a closed castration, so the tunic is still present. The muscle and a small vessel are adhered to the tunic. This small vessel is the main culprit for the post-op problem of scrotal hematomas. The cord and major vessel are not attached to the tunic. I used a pair of Carmolt forceps to make the crush bed. The millers is formed, the Carmolt is removed, and the knot placed in the crush bed, then follow with 4 to 6 ones. With closed castration, it is very important that the ligatures are super tight. Otherwise, the tunic can slip and ligatures will slide. I replace the clamp a little higher and place a second millers. One technique I have seen is to place several clamps on and then start ligation. Be carefully with this technique as you don't want to place a knot on tissue that has been engorged, due to multiple clamp placement. I prefer to keep it easy and just use the one clamp. When you tighten, you should see the knot dig into the tissue. Always leave the golden centimeter when cutting, and always try to avoid leaving crush beds in the dog. Check for bleeding and then push the vesica cord back through the ring. Sometimes surgeons will try and remove the inguinal testicle through the initial incision. I usually make a separate incision, as the urethra can prevent easy access to the testicle. So the wound is closed as normal, except there are just 2 fasciicides. Close with a continuous pattern and then intradermals. I finish the layer with the surgeons, trim the tail and then take a bite cranial to the knot, so it is held down and will not stick out of the intradermals. I finish with an Aberdeen, but I prefer surgeons as they will never unravel. One advantage with an Aberdeen knot is that it is easier to bury. Try and leave a small hole for burial. On finishing, glide the needle through, close to the knot. To bury, put some gentle force on the suture and using forceps push the skin over the knot. With an Aberdeen knot, it is important that the exit of the needle is a good distance clear of the knot. And remember, on finishing the Aberdeen, send it through twice. These intradermals aren't great, so I do a patch-up so the knot can't pop out of the skin. I place an intradermal mattress suture. This is basically an intradermal bite on one side and then the other side. And then tire surgeons, I usually use 2 metric 30 for this. Stabilize the other testicle. Choose a location where no vessels are evident. Cut through the skin and fascia layers, but not the tunic, so we can do the close method. Always be aware where the urethra is. I use a clamp to keep the testicle stable and stop it flopping around. Now we just repeat the technique, placing 2 miller's knots in crush beds. Check for bleeding and nudge back through the ring. The fascia layers are closed with a continuous pattern, and both tails are cut off, instead of continuing into the intradermals. This is to show you a different method. To start the intradermals, we place a subdermal anchor. Take a subdermal bite of each side, at a level which is lower than the dermis. Tie with a surgeon's and then snip the small tail. Now go through the subdermal and come out in the intradermal position at the end. I pulled a little too hard then and the suture snapped off. I just have enough suture for a couple more throws. So I will have to use the loop to bury the knot. I cut the loop low down, giving me a small strand. I just managed to thread the needle and now I will pass the needle through close to the knot. Slightly pull on the suture and push the skin over the knot using forceps. I am struggling because the piece of thread is so small. So what I have to do is pass the needle partly in and then thread the needle.
Please support the charity. Subscribe for free.